you think, okay, great, I'll connect to this feed and I'll get the data and off to the races. Unfortunately, that's not the case. And so we do spend a lot of time educating folks that have not tried to go down that path themselves on the complexity, the number of different connections, the different formats, the multiple duplicates, even if it's all coming from something as simple as a medication. Well, you have some data coming from the EMR, some coming from the pharmacy. How do you unify that into a single picture?
Welcome to Concept to Care, where we hear candid stories of success and failure, discuss strategy, and dive into the details that offer advice on what to do and what not to do in health tech.
Whether you're a seasoned pro, growing your career, or just starting out, our aim for this podcast is to be relevant, real world, and tactical. We're dedicated to not only entertaining you all, but also empowering you with actionable insights that can be applied beyond the podcast, one concept at a time.
This is Angela.
And this is Omar.
Welcome to Concept to Care. In today's episode, we're talking to Ada Glover. She's the Chief Product Officer and co-founder of Zus Health, a patient health data platform designed to help provider organizations drive impact with a comprehensive understanding of their patients and populations. At Zus, Ada leads the product design and clinical teams. She loves setting strategy, digging into complex data, and creating care team experiences that are simple and relevant. You're going to hear about how she got to Zus. Additionally, in this episode, you'll hear about the founding story of Zus, what its strategy is. We're going to do an introduction on healthcare data, including interoperability, and we'll talk to Ada about her outlook on electronic medical records. We hope you enjoy this conversation.
Ada, welcome to Concept to Care. We're excited to have you.
I'm very excited to be here. Thank you so much for having me.
Yes, of course. We were really excited to get this on the books. Just to start things off, why don't you go ahead and tell us about yourself?
So I think from a career perspective, I'm someone that's really passionate about solving sort of big systemic problems that have complex stakeholders, complex dynamics, and have a lot of room for technology to make a difference. That sort of led me to a career in healthcare, although that's not where I started. And it's also led me to a role in product management that really brings together some of my business expertise and skills. I started my career in management consulting, as well as some of my sort of technical intuition and expertise as well. There were moments in my education where I thought about being a software engineer and have always sort of enjoyed tinkering and building things. So a really nice way to combine those two passions. I'm currently the Chief Product Officer at Zus Health, which is a startup focused on the patient data interoperability space. Prior to that, I was at Athena Health and led product teams across that organization. And then outside of work, I live in the Boston area, grew up here, love it here. I'm a busy parent of 2 elementary age kids, which is a really fun age. And then you'll occasionally in the warmer months find me on the Charles River. I did rowing on and off throughout my education and have picked it back up in the last couple of years and really enjoy it.
You mentioned that you were in consulting. That's where you started your career, and your career has spanned in ed tech, doing product, and then you switched careers and now are in health tech at Zus. Tell us a little bit about how you were able to make those transitions, both in function as well as industry, and what advice do you have for folks who are looking to make similar transitions?
Yeah, it's a great question. I think in all of those moments, it was sort of a combination of luck, a lot of self-reflection and thinking about both where do I have skills and expertise, and what am I passionate about? And then really thoughtful, intentional patient networking with a clear story about why. So my first jump was from Bain, where I did management consulting, into the edtech world. I was fortunate enough to do some pro bono work in education and really appreciated sort of the mission-driven aspect of it, and was also interested in doing something a little bit more operational. Somebody I worked closely with had the opportunity to start this new edtech startup, and I, through a number of conversations, was part of the founding team there, but was able to position sort of my expertise from that consulting work, as well as my education in the tech, with a tech background, and just desire to roll up my sleeves and work hard and join that team. I think my transition from Zurn, which is my edtech startup, to Athena was a little bit more intentional. I was interested in moving back to the Boston area. I was interested in continuing that sort of mission-driven thread. There were a lot of things I loved about education, but I also understood that the role of technology in the classroom is often sort of secondary because that relationship between teacher and students is so precious. And so thought healthcare would be a really nice sort of lateral move that had a lot of the same sort of ingredients of education, multiple stakeholders, big data problem, sort of structural, mission critical area on a national scale. But because the interactions were much less sort of consistent and much more disparate, I thought the role for technology would be more powerful. And so I was able to sort of identify that, do a ton of research on the various players. Athena Health came up time and time again. And I also learned about myself that I wanted to be in an organization that had a larger product management presence. I sort of figured it out as I went in my first startup and really wanted to be part of a team. And Athena sort of checked all of those boxes. And then I spent a lot of time really perfecting that story of how does my education expertise translate to healthcare? Why is my startup experience compelling to a larger organization? How does my consulting experience help me with some of the client management, problem framing, strategic thinking? And then leveraging sort of my network to find the right introduction. I was fortunate enough to have, 4 or 5 months to do that job search, and in many ways landed exactly where I wanted to be. So a little bit of luck and some intentional thinking and storytelling along the way.
And Ada, you mentioned, a piece of advice that you have is to be very clear about your ask.
Yeah. So one of the things that I learned from that experience is to just, refine that story, be patient about who you want to be introduced to, make those asks really clearly and concretely, and have at least some constraints to your ask. I think I often talk to folks that are looking for a career jump and are very open-ended. I don't know if I want to be in a big company or a small company. Do I want to be in a tech-centered company or a care delivery-centered company? Do I want to be on the data side or sort of the user experience side? There's so many parameters. I find it really difficult to help folks in those moments. And so really doing the legwork of, hey, I noticed you are connected to these 5 people. I'm interested in these couple of companies. The reason is, at the time, it is important to me personally to be in the Boston area. I want to be in a larger company. I want to be in a technology company that powers a core workflow, such as an EMR. Like, just having that clear story makes it a lot easier for folks to support job seekers. And sometimes you have to guess and be willing to be wrong, but I think that ties into sort of my skill set as a product manager. Hypothesis-driven. I'd rather have a clear hypothesis and an ask and put it in front of a potential user to have them tell me, nope, garbage, than to sort of ask very open-ended, unspecific questions and then be left, without that engagement.
Yeah, so I heard you say a couple of things. So number one, don't be afraid to talk about transferable skills, even if they don't directly apply. I think a lot of times what happens is you read a job description and it's completely intimidating. What I need to have, how many years, I need to have these skill sets, and that may not always be the case. And so if you have transferable skills, you should be able to speak to those. And then the second thing that I heard is a lot of times I feel like the tendency is to be very broad with keeping your options open. And I'm hearing you say, no, you should put your intentions out there, be very specific so that people can help you.
Yeah, I think that's right. And it may mean that you have 2 or 3 sort of floating hypotheses on your intentions at a time. Transparently, I was talking to a couple of healthcare organizations and a couple of education organizations, and had a slightly different story there. And that's okay. That's a natural part of the search, but in those individual conversations, being specific.
Yeah, I agree with all those sentiments. It's a bit frustrating sometimes when you get those conversations or those asks and you're like, well, please, you need to do a little bit more work before you talk to me. But 100% aligned there. Let's talk about the founding story of Zus Health a bit and how that was informed and the inspiration there. You are the co-founder and the product leader of the business. What was the inspiration and founding story of Zus Health? And then what sort of problems did you guys set out to solve, and how's that evolved over time?
I'll start with my story, and then it sort of meshes up with the rest of the founding team of Zus very nicely. So I was at Athena Health, and a lot of the problems that I was personally working on were how to bring more longitudinal care into the EMR. And I think EMR is driven by a lot of these top-down meaningful use requirements, as well as the mostly fee-for-service foundation of our healthcare system, are very transaction encounter-oriented. And I was talking to a lot of customers that were saying, well, I'm a value-based care organization. I want to treat a patient over time. I want to understand what's happening with them. And I want to bridge my population health strategy with my EMR. And watching this happen, and yet having sort of a long list of requirements to check for the next round of certification and the next set of features was something that always pulled at me. And so this was a problem that I was very eager to solve. In parallel, so Jonathan Bush, who started and led Athena Health for over 20 years, I had the opportunity to cross paths with him a handful of times during our mutual time at Athena. And then this was also a problem that I think was near and dear to his heart. And in fact, there were many efforts in the organization to try to edge towards this problem. But after he left, he sort of popped back up a couple of years later and said, you know what, I want to try to solve this problem from the outside in without the burden of all of these workflows, all of these requirements, all of the claim-based polls. What would it look like to really create a data platform that can serve ongoing comprehensive care? And so this is where luck comes in a little bit. I was starting my job search and ended up being reconnected with Jonathan for just a career advice chat as I was starting to think about what I wanted to do next. And he started talking about, I want to start this thing. I want to make it real. I think I'm going to call it Zus. And that was the beginning. And I ended up helping put together the vision, do some of the early research, and become part of the founding team. And so I think, again, this passion about a specific type of problem married with the right opportunity brought me here. From a business perspective, I think the fundamental problem we're trying to solve is that healthcare data is still, and patient data in particular, is very siloed. And moreover, when you do start to see interoperability happening, it's often happening with a delay. So that freshness that you can act on is missing. It's also been very difficult to make sense of because there are numerous different formats. Things are still very much modeled after the document, the facts. So it's difficult to make sense of this data. And then it's difficult to actually build experiences on top of it because often it's sitting in an analytical database or a stack of documents. And so the vision was really, what if we broke down those silos, made the data clean and usable and actionable, and then let folks really innovate the kind of experiences you could build with a different sub-basement, a different sort of underlying infrastructure. That led us to initially focus pretty broadly because we're thinking about that stack of how do you aggregate data, how do you keep it fresh, how do you clean it and make sense of it, and then how do you start building workflows on top of it. In particular, we saw a lot of digital health startups that were all building very similar care team-facing applications and thought, what if we could demonstrate the power of building in a less siloed way by building one of these applications? I think what we found was it's a lot of scope, a lot of vision, and part of my role has been to focus us down. And so today, our core product is called the Zus Aggregate Profile, the Zap, which really focuses on aggregating, monitoring, and keeping up to date, cleansing, and sort of micro-summarizing this data for very specific workflows. That was a lot, but hopefully helped give you all a sense.
Yeah, we're excited for this episode, and we're gonna break things down. So we'll get into the data, and it might get a little technical, which is fine. I wanted to know a little bit more about who your customer is. So you talked about these population health entities needing a longitudinal record?
Yeah, so I think what's interesting about Zus is we have a somewhat diverse customer base. I think where we were born in the middle of COVID, in the era of this digital health boom. And so a lot of our early adopters, tried and true organizations were these tech-enabled sort of digital health, sometimes call them like focus factories that really zero in on a single population and sort of leverage the best of hybrid care to deliver sort of an always-on coherent experience. So some of these organizations are helping provide wraparound care for oncology patients, or maybe they're innovating in the primary care space, or maybe they're extremely focused on a subset of populations that have certain mental health issues. And that's really the core place that we started. I think what unifies this group is this always-on care, a focus on sort of technology as a driver for innovation, and also this role of being accountable for the full patient experience and set of outcomes, but not necessarily being in the middle of a health system where they have their tentacles in every last part of care. So that was sort of where we originated. I think where we've expanded as we've grown has been two areas. One is kind of more traditional medical groups, often ones that are ambulatory focused, and so have this sort of blind spot visibility challenge around what's happening with their patients outside their practice, as well as value-based care organizations that, again, are providing these types of services on a greater scale, maybe working with some of these brick and mortar smaller practices, helping them take on risk. But I think the key characteristics are interest in that entire patient journey, that treatment relationship where they're providing care to the patient, and oftentimes lack of visibility into what's happening and in scenarios where the patient is likely to move around outside the organization.
That makes a lot of sense. Totally could see how that is high value. You're broadly solving for an interoperability problem, but tell us a little bit more about the product itself. You mentioned Zus Health, aggregated profiles, and Zaps. What is that exactly? How should folks expect to see that take form?
Yeah, absolutely. So the Zap, we like kind of fun Z originating names, is sort of our name for the patient profile. And we really think about that being a living, breathing object. So we do a couple of things. First of all, we connect to as many external data sources as possible. Some of those are kind of out of the box national networks that we pre-connect to. Some of our customers are starting to also bring their own connections in the form of more local or regional data sources. We also try to, whenever possible, connect to our customers' EMR directly so that we really bring together a comprehensive view. One of the other things we do in this phase is constantly refresh the Zap. So the way a lot of these national networks are built, they're query-based. You have to go out there and refresh, and traditionally that happens only when the patient is being seen in the office. Well, it turns out that these always-on care models really need to take a proactive stance. So we'll do things like try to make sure that the discharge summary is available following a hospitalization, which is a more proactive mode of care. All of this sits on a Fire-based data store, so we're fortunate to have come about in the era of adoption of Fire and agreement there. And so we've adopted that holistically. Everything's in a patient-centric view, so we unify a patient's identity, which means that if multiple folks on Zus are treating the same patient, they get seamless care coordination as part of the experience. And then we build what we call lenses, which are different views of the data. And these can work at the individual patient level or could be rolled up for more of a population view, but really try to pull together data from across all of our resources to tell a coherent story. So you might have a lens for the chronic conditions that a patient has been diagnosed with, but in addition to just the last diagnosis date, you may want to know information about whether this is chronic, information about who else has diagnosed it, what's the specialty of the provider that diagnosed it, all of this metadata that lead to the second and third tier types of questions. Another example is, again, that post-discharge example. Turns out You need to know when the discharge happened, but also what medications have changed. And did the patient actually pick them up? And what other orders were placed as part of that discharge? Is the patient home health? Have they been admitted to a SNF? We're trying to chase down that complete story through both our data networks, but then also how we summarize the data. We manifest those summarizations into our own UI, which is embedded in a handful of EMR partners. We also have our own application, and then we provide our customers with an analytics-based access that they can use to power their own analytics. We're working on some out-of-the-box tooling there that's fairly lightweight, or they can unify it with their existing analytics stack.
That's really cool. As you were talking, I mean, Angela's nodding as well, but I feel like some of these use cases, like we're in many of the startups that we've been a part of, we were trying to solve those with data or different tooling sets. And so it resonates a ton. For the unfamiliar buyer, healthcare is riddled with lots of different specialties, personalities, expertise, skills. I could imagine a technical product like this is pretty difficult to understand or like really conceptualize, because you mentioned a lot of constructs there, like lenses and like so and various profiles. And so like how do you guys solve for that? Because I imagine it's like pretty abstract at first and hard to explain. And where's the magic happening? How are you getting it to be more palatable?
Yeah, I think that's a great point. And I think the fact that we span across these various steps and create this more unified experience is also unique. So you might have somebody that's an expert in one string, but helping tie it all together into a coherent product is definitely something that's a challenge. I think two things. One is just explaining the complexity of the problem, right? You think, okay, great, I'll connect to this feed and I'll get the data and off to the races. Unfortunately, that's not the case. And so we do spend a lot of time educating folks that have not tried to go down that path themselves on the complexity, the number of different connections, the different formats, the multiple duplicates, even if it's all coming from something as simple as a medication. Well, you have some data coming from the EMR, some coming from the pharmacy. How do you unify that into a single picture? What if the patient switches from a generic to a brand, but is essentially on the same medication? How might you treat that? How might you group those, right? All of these little nuances, the more we can bring examples, use cases, and then statistics on the complexity of the data, the more this really comes to bear. And then there are increasingly folks somewhere in these organizations that have rolled their sleeves up and poked at some of these things themselves and are realizing how painful it is.
I think along those lines, one of the things that you talked about was FHIR, which stands for Fast Healthcare Interoperability Resources. Can you talk about what that means and why that's important?
Yeah, absolutely. And thank you for breaking down the acronym. We have so many acronyms in healthcare, and I know those can be hard to keep track of. So FHIR is sort of in the long list of different healthcare data standards that have come about over time. I think two things in my experience that make it unique. I think one is it's not necessarily transaction oriented. So I think the first places where interoperability really blossomed in healthcare was I need to send a claim from here to there. I need to send an eligibility transaction, an order, a prescription, right? But that doesn't have the depth of the full picture of the patient. You then have these lovely things called CCDAs, which were documents, XML behind the scenes, that are assembled to represent an entire encounter or sometimes a longitudinal view of the patient. But they were documents, right? It's a snapshot or a one-time event. I think FHIR is a big push in the industry to break things down into their component pieces. So you may have a condition resource. Even medications are broken down into a medication statement, sort of a statement that a patient is on something versus a request, so a prescription most often, and a fill. And so I think it's the first standard that really gets to that layer of depth and is really targeted toward the provider user. There are a few other standards that have gained traction in more of the research and realm. And so I think the design of this, I think, is purpose-built for a lot of what we're trying to accomplish and do. And second of all, is we saw, as part of this 21st century Carrier's in the latest round of certification, sort of a more government-driven enforcement of adoption. So this is across the board. Some of the first patient access APIs for payers are leveraging FHIR. For providers, leveraging FHIR. There are multiple industry groups that are really thinking about how to transact and how to integrate through FHIR. And so it's really becoming a common language in a way that I'm really excited about. Still a really long way to go. Most of the data we see today is still kind of these older school formats, although there are pushes to adopt FHIR. Most EMRs and payers may expose data to be read in FHIR formats, but you have to write it back in proprietary forms. So a long way to go, but a lot of progress.
So I'm very familiar with the discharge use case. My current place, the current startup, we leverage ADT feeds. We want to look at the I'm just going to name drop the file, but the ADT, I think it's like A03, right? There are fields that we're looking for. Sure. We're trying to find our patients that are getting discharged, and we want to catch them as soon as possible so we can impact conversion, really. Like that's for us. So that's like one jobs to be done, right? Product people love the jobs to be done framework. What are the jobs to be done broadly? And what are you seeing most commonly? Like what is the number one, if you were to say the distribution of your customers, like what are they all trying to do predominantly?
Yeah, I think that's a great question. And I think about it as like I'm a framework person, 3 categories. I think one is finding these blank or stale slate moments where you're about to see a brand new patient. You might make so many decisions if you understood more about who this patient was. How long should their appointment be? Who should be at that appointment? Can I pre-populate some of my documentation? Can I tailor some of the questions I'm going to ask? Organizations put a tremendous amount of work at the patient level in helping support these new moments. And so that was sort of our first area, this get up to speed moment. And that's where embedding in the EMR and extracting and summarizing all this data has been really powerful. A lot of it is just getting a reasonable portrait of 2 things. One is the patient's medical history. So you just understand from a human to human perspective what's happened to you. Patients are not very reliable sources of that information. I know we've all been handed the clipboard. And then 2, what's a sense of this patient's risk level? Is this somebody I have to sort of bear hug and work really closely with and give tons of support? Did they just get discharged from the hospital last week and suddenly it turned out they had no PCP and then here they are? Or is this a reasonably healthy person? So you can change the resourcing, the tone of the conversation, et cetera. So that's a really major job to be done that actually has a lot of subcategories before it. I think catty corner to that is re-engagement. I think we work with a lot of folks that work with very vulnerable populations whose phone numbers may change, who may be difficult to reach, even though you know they need you. And so we have these really magical stories of a difficult to engage maternity patient that suddenly went on a baby aspirin, and that's an indicator of a key symptom that indicates rising risk. And suddenly, with the new phone number you found or the new piece of information, you are able to re-engage that person in a more effective way. So that's another piece, is sort of in these in-between care moments, how do you make sure you don't have those blind spots? The next area is how do you provide extra support when emergent care happens? Yes, the discharge summary is a really simple one, but again, our value proposition is really how do we provide all the context behind that? It's not enough to have just that ADT. You need to know what happened, where are they going next, what instructions were they given, did they follow those instructions, who are their other caregivers and family members, like how do you really help support them in that moment? So that's a really important one. We're looking at other similar moments like, oh, this patient might have an upcoming appointment with a specialist. Maybe this is a moment to follow up afterwards, really see how things are going. And then lastly, there's these ongoing care, so quality measures, care gaps. One thing that we often see is some of these quality gaps really require clinical data points that might not be available through a claims feed, for example. And so how can we marry that information with a more clinical view and save somebody an extra trip to the lab, or realize that, actually this is a worthwhile outreach? How do you see if that patient did follow through with that specialist, get a grasp on what those notes were and whether their meds changed so you can follow up accordingly. So those are some of the use cases. I think the common thread here is these moments where you need to summarize and where you as this sort of responsible provider may have some of these blind spots, but a lot on the line in terms of the patient's outcomes and your own performance in some of these value-based care arrangements.
Ada, from a product perspective or the technology perspective, this is all made possible by sitting on top of a couple data networks. There's an orchestration piece here, and there's obviously a lot of proprietary on top of that. But can you just talk a little bit about the networks that are being leveraged and why you leverage them? And then what's actually IP versus not? And, there are competitors in this space. So if I know it's a three-parter here, but if you could talk about the competitors as well, would love to understand, kind of get that breakdown.
Yeah, so I think we're really fortunate to stand on the shoulders of giants. I think there's a wave of both more government-funded local and national networks, as well as other organizations that have realized this need. And so infinite gratitude to those that came before us, as is always the case. We leverage partners across a couple of different areas, EHR data, mostly through Commonwealth Care Quality, these big national health data exchanges, although starting to tap into more regional players as well. The hospitalization we've talked about, ADT, pharmacy, and some lab data as well. And so having that multi-layered combination, I think, is something that's really powerful and providing a little bit of that one-stop shop from the perspective of not having to then unify all of that data and invest for our customers to invest their own resources in building that single view. I think in terms of what's unique, I think it's a couple of things. I think one is, as I mentioned earlier, because we have access to a diverse set of data sources, really trying to think critically about how we can bring that together. Whenever possible, I also mentioned we try to understand what's happening to the patient within our customers' walls so that we can use some of the hints they may have to think about what's coming next. And so really building out that intelligence, I think, is something that's unique to Zus. I think second, just all the normalization cleansing. A lot of folks are doing it. I think one of the things that's unique to us is because we're building some of the summarizations, some of the UIs, starting to build out some of the analyses, we see all of the complexity and the warts and the mistakes and the opportunity to improve. It's very different, I think, to look at a data quality score of what % of your conditions have a valid code on them and look at it from that technical layer versus to identify the 99th percentile of most longest problem lists and go through them side by side with a clinician and realize that you could rule out a chunk of those because they're actually symptoms and not conditions, that you could collapse a bunch of them into a single grouping because they're all just variants of the same diagnosis that aren't clinically significant. And I think that's the kind of work that I think makes Zus unique and helps continue to fuel that value proposition. I'd say the last piece is because we have that sort of unifying patient behind the scenes, longer term, I think there's an interesting opportunity to really fuel care coordination beyond this more network-based, more ambient observation of what's happening with the patient.
Thanks for sharing that. So with Zus, there is this longitudinal record versus, I think historically the data has been more fee-for-service oriented where it's episodic. And so
Yes.
With a longitudinal record, can you bring it to life and talk about what it means for a member or a patient and maybe share any success stories that you've heard from your customers?
I think from a member's perspective, there are a couple of things that are really important. I'll touch on 3 of them, and I think some common themes. I think one is not having to be the carrier of all of that information. It's one thing to roll your eyes when you have to fill out the same patient history that you always do in the office, but it's another thing to really have a complex set of conditions that you just truly don't know. What medications are you on? What happened? Or maybe there's something you're not quite confident about and not willing or comfortable talking about. I think having an informed counterpart in the form of a provider that can really tactfully guide you through that, make you feel comfortable, take that burden off of you is really powerful. So I think that's one. I think two is the ability to, again, have that proactive intervention when you need it most. So, we go through our lives mostly, hopefully reasonably healthy and not wanting to go to the doctor. And in these moments when something does happen, it's often overwhelming. You have to navigate a phone tree, figure out who do I even call. Having a more proactive sort of partner on the side of the care organization, I think really changes the tone. And then I think lastly is those additional resources and right sizing the care. How do you make sure that you are given the resources that make sense given your situation? And we recently had a provider that we work with talk about a patient she was seeing who's a veteran and had spent some time in the VA system and now was seeing her. And she was like, he couldn't explain his medical history to me. Using the tools I previously had access to, I never would have understood that, but I was able to see sort of this complete picture of his past history and totally change the tone and be much more prepared in that conversation. And I think have a much better start to the patient relationship. And then I think one interesting thing in the industry is we do have this push towards more patient-mediated access, all of the APIs. And we've often played in this area, especially that intake moment, like this question of, does it make more sense to have the patient bring together this data, review it, confirm or deny it, and take on this burden, or arm the provider with the information and let them facilitate the conversation? I think so far we focused on that latter use case because especially given most of our customers are treating more complex populations, there's so much for them to process, and they can bring that additional layer of nuance and tact in their own approach to the conversation and just take that burden off the patient. I do think that long term, there's an accessibility piece, and then as we broaden our scope and touch a diverser set of populations, there may be some where that patient is a more critical part of the conversation, and I'm excited to step into that world as well.
Switching gears here a little bit, looking for a spicy take here, but let's talk a little bit about the EMR landscape. We saw the consolidation of EMRs a couple years ago, and then now I feel like that narrative doesn't even make sense to me anymore. I encounter new EMRs. Like when I think I know them all, I actually don't. And given that from where you're coming from, and then a lot of your customers are trying to integrate EMRs, can you just tell us a little bit about the landscape? Like, what is currently out there? What attributes should like a health tech builder be looking at? Like I'm often asked, like, what should I pick? And I don't even know anymore.
I'll do my best to carefully answer this question. So I think you're right that like the bigger players haven't evolved a ton. I think we encounter a lot of folks using Athena and Elation, which are both, we're integrated with both of those. I do think we've seen a lot of sort of innovation at the smaller end, and I'm excited by a lot of the efforts there. I think those newer EMRs, some of whom we work with, have worked really well for folks that are really trying to build their own or innovate on the workflows. I think where it's tricky is as you start to hit scale and start to have more complex requirements when it comes to revenue cycle, when it comes to departments and organizations, when it comes to quality reporting. Like EMRs have become this smushed together long laundry list of features that are expected. And from an industry perspective, I think that's going to be really interesting to see. Like either all of these point solutions get easy enough to integrate and comprehensive enough that you can truly sort of build a bear for your EMR, or we're going to continue to see little pockets of innovation and workflow and APIs in certain places. But it's going to be really hard once you start worrying about claims and quality programs and like just all of these must-dos to hit every last requirement, which pains me to say. I think the other trend you see is, okay, I've got an Athena, I've got a bigger EMR, and I'm going to build on top of it. I'm going to build my own veneer. And I think folks have been really successful for many workflows. And I think the EMRs have leaned into that and responded to it really nicely. There are still a few holdouts, especially for these critical transactions. Like you still can't really sign a pharmacy script or an order. It's tough to really sign off on a note without then logging in. And I think until that's solved, it's going to be hard to bridge. So what I've seen people do is core clinical workflow. I'm in an encounter documenting that happens in my EMR. Kind of everything else happens in a newer, more flexible tool or something I built myself. And then I sync the critical data. What's cool is we see a lot of folks using Zus embedded in their EMR and Zus embedded in their care management homegrown platform to help be that bridge. But yeah, I'll be curious to see what it looks like 5-10 years from now and whether anyone's broken through or maybe we start to unbundle some of those long tail of requirements.
Oh,
I don't know if that was spicy enough.
No,
Might have been too careful.
It's good. It's spicy. So I want to like the veneer model. I'm a big fan of the veneer model, as you call it. Where is that going to hit a wall? Because I'm still waiting to see. I'm going to run into something, I'm sure. So what do you think folks are going to start to hit and where they can't move maybe a metric or solve a use case or something?
I think the simplest wall that I see folks hit is just the like that ordering moment, right? It's still a moment where folks have to hop in and out. I think the other piece is I think where the underlying construct is very encounter note based. I think there is also this question of like, okay, my veneer has a mental model of something a lot more longitudinal. My underlying system is something that is much more, it's either an encounter or it's a very lightweight note. And so how do I solve that data model problem? I think that's the other piece that's tricky. And then I'm sure there's just a long tail of detailed settings, preferences, things that are important for optimization on the back end that are probably solvable, but maybe some of those aren't exposed by API, et cetera.
You mentioned that you have partnerships with Elation and Athena. Talk to us more about those partnerships. Why are they valuable for Zus, and how does it help with your go-to-market and maybe even their go-to-market?
And then we also have integrations with Healthy and Canvas, so I don't want to. They were our early partners, and definitely don't want to skip past them. So I think a couple of things. I think first and foremost, just providers and care teams hate context switching and dual pane of glass. And so anything we can do to alleviate that off the bat, the better. And so I think that's been tremendous. I think we've also been able to leverage either sort of deeper partnerships or the more mature APIs to create more integrated workflows. So it's great if you can see a summary of your patient, but how do you actually incorporate that into your chart, into your encounter? Because folks still really think of the EMR as kind of their source of truth that they're accountable to and document in. And so being able to bridge that has been important. From a go-to-market perspective, I think we've done a lot of really exciting work with the EMRs to share what we're doing. I think some of their sales teams have been really great about bringing this to folks that might be interested. And I think the biggest lever has just been the ease of implementation. I think customers that aren't using one of our integrated EMRs could get started with our app, but that's a new screen, something new to log into. And so while that's great at a smaller scale, it's just difficult to roll out. Whereas if we are in a supported EMR, we can flip a couple of switches and suddenly everybody's up and running, which is really powerful.
Big fan of flipping a switch and get up and running.
Exactly.
So where does Zus go from here? Tell us what's next.
Yeah. So, In many ways, I think Zus has been around for a couple of years, and we've got the core product up and running. And a lot of what I'm excited about this year is refinement. So, back to the being self-aware of what you're passionate about, what gets you going. 0 to 1 is really interesting and fun for me, but it is uncomfortable as well. And I feel like we're finally in that 1 to 2 phase where the use cases we're focused on are resonating. People are asking us for more and better. And so a lot of the theme is that. And I know that's not, it doesn't make headlines in the same way, but personally, and as a product manager, it's really a fun phase to be in. So we're continuing to make our sort of get up to speed experience better. We just rolled out the overview that summarizes not just by data type, but tries to bring together a picture of key indicators. We're starting to think about how can we layer on risk factors on top of that? Do we start looking at more advanced techniques for summarizing that data beyond filtering and grouping and et cetera? So a lot of it is about how do we take the capabilities we have, make them better, smarter, more reliable? I think the other piece we're looking at is taking that core asset of that universal patient identifier and starting to think about what are these collaboration, care coordination moments with that summarization of the Zap? What if you attach that to an outbound referral so the specialist has visibility into what's happening? That's a second thread that we're looking at. And then I think third, there are some key indicators that there's room for us to support our customers on the analytics side. We have some pretty frequent query request workflows. We're not trying to be, at least anytime soon, the behind the scenes heavy duty quality engine, but our data is uniquely positioned to identify certain types of care gaps, certain types of risk factors, and can we be better and smarter about surfacing those the same way we do at the patient by patient level. So those are some of the things we're doing, and then we'll continue to work with new EMRs and kind of grow our partnerships.
I would be remiss if I didn't ask you about how Zus is thinking about using AI or already using AI to make your processes better, your product better.
Yeah, it is the question that everyone's asking and looking at. So I think right now, one of the areas that we're thinking about it, and we've done some small experiments ourselves, is on this summarization front. The long tail of complexity, unstructured data is just so long. We are trying to focus on certain use cases and really break it down. I think my perspective is that for a very long time, you're going to have really good prompt engineering to use AI effectively and safely. And so I'd rather us be the ones doing that, applying that rigorous testing, ensuring that we have traceability for the questions that we get responses to. And so that's where we're starting our exploration.
Well, that makes a ton of sense. We are going to maybe zoom out a little bit and talk about health tech in general. From where you sit, where do you see limitations of technology and what's actually feasible in terms of payment models, data limitations, data standards, regulatory and compliance, technical feasibility?
I think a couple of things come to mind. I think one that will come with time, and I mentioned earlier, is I think we're very focused on reading data. I'd like to see us equally as focused on writing data, especially as we think about not just tossing information over the fence, but actually being able to drive workflow in an interoperable fashion. So hopefully FHIR starts getting its legs there. And I think in some cases, we're starting to see a little bit more sort of workflow-based exchange. I think from a regulatory compliance data perspective, one of the things that I think from my angle can't come soon enough is the payer-provider data exchange modernization. I think in cases where folks are taking on risk, it's all flat files, SFTP, several weeks later. And the truth is payers and providers have complementary views of patients, and there's some comfort to work through. And I know we're starting with use cases like prior authorization, But I'd love to see some of that accelerate, and we should see it happen over the next couple of years. I think CMS has also done some cool things with data at the point of care and other pilots, but I think that's an area that I'm really eager for. And then I think I'd be remiss to not sort of talk about TEFCA a little bit. So I think this whole data exchange ecosystem could look very much the same, or I'm hoping it looks very different several years out. We're at this moment where we've got the first big wave of QHINs, and folks are starting to participate, but haven't seen full uptick. We're expecting to start participating in those exchanges at some point this year. So I'm very eager to see how that all plays out. And there are a couple of different layers to it. One, it could help consolidate, right? There's that network of network approach that could help just create more seamless integration. So that's exciting. I think two, they are looking at expanding to additional use cases. The first one is individual access. So patients could more meaningfully gain access to some of their records. We'll be curious to see how that plays out. And then three, while today I think there's an acceptance of CCDAs and sort of these document-based exchanges, I think there is a look ahead to via sort of more granular data-based exchanges that could be really exciting. So, we're staying close, working hand in hand with others in the industry, and would like to see all of those things happen, and want to be active participants in that journey.
Incredible. Given all that, it's a lot, right? Like, it's complicated, it's archaic, and sometimes it's, or not, right? Or there's a lot of, I don't know if red tape's the appropriate word, but there's a lot to go on there. And so for either like newer product managers or some of the IC product folks, like, take those constraints, like, how does one still innovate? Like, I'm coming from fintech, and or maybe not fintechs, like, I've come from other tech environments and I've been able to do so much. Like, how do I still build the stuff I need to build for the user when all of this is going on?
Yeah, it is a conundrum, and I think it's important not to get immune to it and become complacent. So I think that's the first piece: is stay close to other industries, see what's going on, ask the questions, because I do think it's easy to sort of live by the latest checklist of certification requirements or whatever, and lose sight of some of these things. I think one is a lot of, while these limitations exist, there is constant progress in the form of these pushes, these waves of innovation. I just talked about one of them. I think it's important to lean into them and find ways to, stand on those shoulders and innovate further, right? So you could easily take these networks and do the bare minimum and have a list of documents. But what else could you do? There's actually so much potential within the constraints. And if you map that back to the jobs to be done, sort of the quality of the user experience, I think punching through can be very valuable, because that may then mean that the next round of innovation unblocks some of the constraints. And that might look different. Like, sometimes that means you have to participate in committees and help sort of roll up your sleeves and become more active. Sometimes that means proving the bright spots of, actually, between all of these constraints, there is that crack of light. I think the other piece is just really paying attention to what users need. I guess in a similar vein, there are a lot of solvable problems in addition to the the more difficult to solve problems. And so continuing to add value there, I think, is really important.
We have reached the very exciting concept closing call portion of the podcast. And so the first question that we want to ask you is, are there any concepts in healthcare that excite you right now?
A little bit outside sort of my core realm, I think one of the interesting areas is folks that are trying to modernize some of the less core, at least less in my sightlines, parts of the industry that are still very nascent in terms of how the role technology plays. So one that comes up, the folks at HouseRx are doing some interesting work around specialty pharmacy and modernizing that infrastructure, and even figuring out how to shorten sort of the distance between the prescriber of some of these complex drugs and how they're filled. And again, this moment where there's a lot of complexity, burden placed on patients that are in a vulnerable moment. So I thought that was an interesting one. There are a bunch of companies looking at DME as well. And I think that's really, really cool to see. I know not a sexy sort of Gen AI type example, but was the first that came to mind.
But it's very real, right? If you are discharged from the hospital, you don't have your durable medical equipment like a bed, special bed. That's a problem.
Exactly.
Yeah.
Are there any frameworks, methods, processes that you've found to be especially useful in your work and that you think others may find useful?
Yeah, so I think two things come to mind. One is, I think, at the high level strategic decision-making front, I love just the simplicity of a what you'd have to believe type conversation. I think folks get really sort of passionate about their vision, what they think is the answer. And I think really breaking things down to those underlying assumptions and having the conversation of, if you believe this market is growing, then this is the answer. And if you believe that this other market is growing, this is the answer. I think just is such a simple framework. And especially as I've moved to more executive roles and engaging kind of broader audiences, that's kind of a go-to. And it's very simple as well. I think can be used at a number of different levels. So yeah, that's the one that came to mind.
Ada, do you have a shameless plug?
Other than this whole podcast being a shameless plug for the company that I work with, maybe a shameless plug for taking the time to help somebody and being creative about your resourcing. I think the industry is in a moment where a lot of folks are in transition, looking for new opportunities, and we've had some great folks do contract work or otherwise be extended members of our team in a way that never be possible on a traditional full-time basis. And I think having a lot of those conversations and then getting creative has been really inspiring and hopefully helps folks as they figure out their next steps. So a little bit of a shameless plug to look out for those hidden gems and help your fellow health techer in the process.
And lastly, where can people get in contact with you?
So probably the simplest thing is on LinkedIn. There aren't many Ada Glovers out there. Otherwise, my email is fine too. But LinkedIn's probably the easiest.
Ada, thank you so much. This is awesome. I learned so much.
Awesome.
Hey, thanks so much for listening to the show. If you like this episode, don't forget to leave us a rating and a review on your podcast app of choice. And make sure to click the follow button so you never miss a new episode. This episode was produced and edited by Marvin Yue with research help from Aditya Treya. We're Angela and Omar, and you've been listening to Concept to Care.